Hi all, let's study the applied anatomy of the major nerves of upper limb. I am Dr. Komla N, Professor, Department of Anatomy, Ramaya Medical College. All images and videos used in this presentation are from textbooks of anatomy and various internet resources. The images are used for teaching learning activities only. This video is done to help the undergraduates understand the clinical anatomy. I acknowledge the ownership of the images and give complete credit to them. Today we shall see the clinical anatomy of the median nerve, ulnar nerve and the radial nerve. The median nerve arises from a medial root from the medial cord and a lateral root from the lateral cord of the brachial plexus. The root value is C5, C6, C7, C8 and T1. The median nerve does not supply any muscles in the axilla or the arm. It enters the forearm through the pronator teres. It gives off a deep branch, the anterior interosseous nerve. The superficial branch or the median nerve will supply all the flexors of the forearm except flexa carpi ulnaris, which is supplied by the ulnar nerve. The deep branch, that the anterior interosseous nerve, will supply all the deep flexors except the medial half of the flexa digitorum profundus. The median nerve gives off a palmar cutaneous branch, passes through the carpal tunnel and then supplies the thenar muscles and the first and the second lumbricals. The median nerve passes through the carpal tunnel before it enters the palm. What happens if the median nerve is damaged? Loss of pronation of the forearm, loss of flexion at the interphalangeal joints of the index and the middle finger, wasting of the thenar eminence, thumb is adducted and laterally rotated with loss of flexion at the terminal phalanx and loss of opposition. The damage to the median nerve can occur due to the supracondylar fracture, compression through the pronator teres, etc. So when the median nerve is damaged, the flexors lose their action. So to test the flexor pollicis longus, you can test by holding the thumb at its base and the patient is asked to flex the terminal phalanx. To test the flexa digitorum superficialis in the profundus, the patient is asked to clasp the hands. The index finger fails to flex. To test the muscles of the thenar eminence, you can use a pen test, mainly to test the abductor pollicis brevis. The hand, as shown here, is laid flat on the table, pen is held above the palm and the patient is asked to touch the pen with the thumb. The opponent's pollicis should normally bring the thumb towards the tips of the other fingers, and this doesn't happen if there is any injury to the median nerve. There is another sign called as Benedict's sign. If the patient is unable to make a fist, then there is a lesion to the upper arm area damaging the median nerve. The patient's index and the middle finger cannot flex at the metacarpophalangeal joint, while the thumb is usually unable to oppose. This sign is called as sign of benediction or Pope's blessing hand. So this is the sign. The patient is not able to flex these fingers. Another sign is OK sign. This sign is used to test the anterior interosseous nerve. When the anterior interosseous nerve is damaged, the patient is unable to pinch anything or make an OK sign with their index finger and thumb. So this is an OK sign. The patient is not able to make a perfect OK. The anterior interosseous nerve is damaged. An important applied anatomy of the median nerve is the carpal tunnel syndrome. The carpal tunnel syndrome is nothing but this compression of the median nerve beneath the flexor retinaculum at the wrist. This could be as a result of obesity or rheumatoid arthritis. In this condition, there is pain and numbness in all the area that is innervated by the median nerve. The fine motor tasks are not possible. There is difficulty in holding small objects because the thenar muscles get wasted. And one important thing to be noted here is the superficial palmar branch arises proximal to the carpal tunnel and passes superficial to the flexor retinaculum, and hence there is no loss of sensation on the central part of the palm. Clinical examination of the carpal tunnel syndrome is done by looking at the thenar wasting muscles. There are important signs called as Fallon sign, Tinel sign, and carpal compression test. So you can note the thenar muscle atrophy due to the carpal tunnel syndrome. So this is a Fallon's maneuver. Fallon's test is performed by having the patients place their wrist in complete unforced flexion for at least 30 seconds. This will bring in pain, resulting in the positive Fallon's maneuver, indicating the carpal tunnel syndrome. Tinel sign. When the nerve is lightly tapped, so there are pins and needles or tingling sensation along the supply of the median nerve. Another test called as carpal compression test or Durkan's test is again the firm pressure on the median nerve results in the pain in the area of the distribution. To relieve the pain caused due to the carpal tunnel syndrome, the transverse carpal ligament is released. This reduces the pressure on the median nerve, reducing the symptoms too. There is another syndrome called as pronator teres syndrome. Here the median nerve is compressed between the two heads of the pronator teres. The flexor pollicis longus and the flexor digitorum profundus get weak, leading to impairment of the pincer movement. Again, this is another test for the anterior interosseous nerve. The sensory changes may be found in the first 3.5 fingers, indicating the impairment of the median nerve. So now let's look at the anatomy of the ulnar nerve. Ulnar nerve is the continuation of the medial cord of the brachial plexus. It supplies the flexor carpi ulnaris, medial half of the flexor digitorum profundus, and it gives off a palmar cutaneous branch to the medial 1.5 digits. Ulnar nerve passes superficial to the flexor retinaculum. It passes through a canal called as Guyon's canal. Ulnar nerve also supplies the hypothenar muscles, the medial 2 lumbricals, the adductor pollicis, and all the interosseous muscles in the hand. During its course, the ulnar nerve also passes through the cubital tunnel, and there are high chances of this ulnar nerve being compressed in this tunnel. Ulnar nerve can also get damaged behind the medial epicondyle during its course. Any injury to the ulnar nerve about the wrist leads to paralysis of all the intrinsic muscles of the hand, and the deformity is known as claw hand. Also, there are lots of cutaneous sensations on the medial 1.5 digits. So here is a test to test the palmar interossei. The patient is asked to hold the paper between the fingers. If he can hold tight, the palmar interossei is intact. Otherwise, the interossei muscles are damaged, which indicates the injury to the ulnar nerve. The adductor pollicis is also supplied by the ulnar nerve. If the patient is unable to hold the paper between the thumb, that again indicates the injury to the adductor pollicis and the ulnar nerve. Here there is another sign called as Fromen's sign. Here the patient is told to hold the paper between the thumb and the index finger. If the ulnar nerve is intact, he is able to do this. Otherwise, the patient takes help of the flexor pollicis longus. This picture denotes a claw hand. This is an ulnar claw hand mainly due to the injury to the ulnar nerve. The lumbricals cause flexion at the metacarpophalangeal joints and extension at the interphalangeal joints. So whenever there is an injury to the ulnar nerve, the medial two lumbricals lose their action, and there is extension at the metacarpophalangeal joints and flexion at the interphalangeal joints of the fourth and the fifth fingers, leading to claw hand. This image shows the wasting of the hypothenar muscles, indicating the ulnar nerve injury. Note this concept called as ulnar paradoxus. Whenever there is an ulnar nerve injury closer to the elbow, the flexor digitorum profundus also gets affected. As a result of this, the flexion of the interphalangeal joints is weakened, and this reduces the claw-like appearance of the hand. On the contrary, if the ulnar nerve is damaged below the wrist, the flexor digitorum profundus is spared and there is active flexion of the interphalangeal joint. This adds to the claw and there is a more debilitating injury, resulting in more deformed appearance. This is called as ulnar paradoxus. This is an image of the ulnar claw hand. The interossei muscles can be tested by cross your fingers test. So inability to cross the middle and the index finger over each other indicates the damage to the interossei muscles. Another test to test the ulnar nerve injury is Wartenberg's sign. In the Wartenberg sign, if you ask the patient to abduct all the fingers and then adduct back, all the other fingers can be adducted except the little finger. This again indicates the ulnar nerve injury. The radial nerve is derived from the brachial plexus. As a continuation of the posterior cord, the root values are C5 to T1. It's both sensory and motor in function. It innervates the posterior compartment muscles. It supplies the triceps and all the extensors of the forearm. The radial nerve passes through the axilla, lower triangular space grooves the radial groove on the humerus, descends down and gives off a superficial branch and a deep branch. The deep branch is a posterior interosseous nerve which supplies most of the muscles of the extensor compartment. The radial nerve gives cutaneous branches to the posterior part of the forearm, the dorsal side of the hand, mainly the 2.5 digits. Common sites of radial nerve entrapment can get compressed at the radial groove, the radial tunnel, and between the two heads of the supinata muscle. Damage to the radial nerve at the spiral groove results in partial loss of extension of the elbow. You can expect only partial weakness of the extension of the elbow. Injury to the radial nerve at the lateral epicondyle. There is no loss of extension of the elbow in this case because the extensor carpi radialis longus and the extensor carpi radialis brevis are spared. Damage to the posterior interosseous nerve. Exclusively the posterior interosseous nerve damage results only in the finger drop. If the radial nerve is damaged high above at the axilla due to the crutch paralysis, then there is loss of extension of the elbow, wrist and all the digits, and this leads to wrist drop. This image is showing a wrist drop here, as there is damage to the radial nerve and hence the extensor muscles are not bringing about the extension. Contrary, due to the overaction of the flexors, there is wrist drop. This image indicates the crutch paralysis, that is the radial nerve is compressed in the region of the axilla due to the continuous usage or the faulty usage of the crutch. This results in loss of extension of the elbow, wrist and the digits. This image is indicating the Saturday night palsy. Falling asleep with one's arm hanging over the armrest of the chair can compress the radial nerve, resulting in defective extensors of the forearm, leading to wrist drop. The posterior interosseous nerve which supplies the extensors are all damaged and there is unopposed action of the flexors. This results in the wrist drop. Note the difference between the Wartenberg sign and the Wartenberg syndrome. As earlier told during the description of the ulnar nerve, Wartenberg sign is the loss of adduction of the fifth finger. So the fifth finger remains abducted. So this is a test used to test the ulnar nerve. Whereas Wartenberg syndrome is the pain, the altered sensation on the back of the hand due to the radial nerve entrapment. So note this, Wartenberg sign is described with ulnar nerve and Wartenberg syndrome is described with the radial nerve. Another important nerve which can get damaged is the axillary nerve injury at the surgical neck of the humerus. So whenever there is fracture of humerus, this axillary nerve, the root value C5 and C6 can get injured. This results in loss of abduction of the shoulder. To sum up, Radial nerve can get injured in the axilla or a midshaft fractures of the humerus. Both results in wrist drop. The median nerve can get damaged due to the supracondylar fracture of the humerus, and it results in the ape hand. Ulnar nerve can get injured whenever there is an outstretched fall or fracture to the medial epicondyle of the humerus. Injury to the ulnar nerve results in claw hand. Thank you all.